As we begin, we're going to take a moment to talk about self-care. The topics we're going to cover may be upsetting for some of you. They may bring up difficult memories of clients that you've helped, or you may have friends or yourself have a child or family member with IDD. The material in this training may bring up feelings and thoughts related to your experiences. We strongly encourage you to take care of yourself not only during this training, but also in your work setting. We will talk more about the importance of self-care in Module 6. So let's start with some learning objectives for what we're going to learn in this module. After completing this training, you should be able to do the following. Define trauma-informed care. Realize that people with IDD are at risk for traumatic experiences. We're going to talk about some of the kinds of trauma that are common among people with IDD and talk about some of those risk factors. We're also going to emphasize that recovery from traumatic experience is possible, and it is possible for people with IDD as well. We want to establish the important role of parents and caregivers and the support network on the road to recovery for adults with intellectual and developmental disabilities. And we'll describe frameworks that will be used to illustrate key concepts throughout the training. So what does it mean to be trauma-informed? The Substance Abuse and Mental Health Services Administration, or SAMHSA, identifies 4 R's of trauma-informed care. Under this guideline, trauma-informed organizations realize the widespread impact of trauma, recognize the signs and symptoms of trauma, respond by changing behaviors, policies, and services to take trauma into account, and resist re-traumatization of clients and staff with trauma histories. So a trauma-informed organization, for example, would recognize that the adults with IDD in their care may have experienced trauma and that this trauma may be underlying some of the behavioral symptoms they exhibit. They would also recognize that physical restraints for someone who has experienced physical or sexual abuse, or seclusion for someone who has experienced neglect, may make symptoms worse rather than helping them to heal. As a result, they would change policies regarding restraints and seclusions and develop positive behavior supports that would address the underlying trauma. These 4 R's are the goals that we hope to achieve through this training. We won't be able to cover interventions in great detail, but we aim to raise awareness of the prevalence and impact of trauma experienced by adults with IDD, to help providers recognize signs and symptoms that may be a result of trauma, and provide suggestions for further skill development to better respond to people with IDD who have experienced trauma. Together, these will help us not only resist re-traumatizing the people we support, but will help end the cycle of trauma, promote growth, and help adults with IDD truly thrive. Being trauma-informed is the foundation upon which more trauma-specific services are based. Kiesler and colleagues identified 3 levels of trauma-informed services. The first is trauma-informed, which reflects the organizational culture and day-to-day practices of an organization. It recognizes that people who are served by the organization may have experienced trauma, and they recognize the importance of being sensitive to the needs of people who have experienced trauma. It has been described as a universal precaution that puts into place safeguards for everyone in order to avoid re-traumatizing someone who has experienced trauma. Trauma-sensitive care focuses more on the ways that people within the organization respond to trauma. It involves putting policies and practices in place to support clients and staff in responding to trauma and promoting resilience and well-being. Finally, trauma-specific services are those that seek to treat trauma through the use of evidence-based or promising treatments, which might include trauma-focused cognitive behavior therapy or eye movement desensitization reprocessing therapy. This training will focus primarily at the trauma-informed level, with recommendations for resources to facilitate adoption of trauma-sensitive and trauma-specific practices. The first R of trauma-informed care is realize. So we'll start with discussing the scope of trauma experienced by people with IDD. Estimates vary regarding the prevalence of traumatic exposure in adults with disabilities and depend on the types of study, methodological rigor, and definition of disability. We'll review a few studies here. Data from the Annual Report of Child Maltreatment in the United States found that 16% of unique victims of maltreatment had developmental disabilities. A study by Cross et al. In 1993 reported that people with intellectual disabilities were 2 times higher the risk of physical and sexual abuse than people without disabilities. Sobesy and colleagues in 1995 found that individuals with intellectual disabilities were 4 times more likely to be the victims of crime than those without disabilities. There is some evidence that certain behaviors are a mediating factor for maltreatment in this population. Externalizing behavior, which has a greater incidence among people with developmental disabilities, appears to be related to an increased risk of physical abuse. Internalizing behavior, or communication and learning problems, are associated with an increased risk of sexual abuse. Domestic violence is estimated to be almost 3 times more likely in families of people with developmental disabilities. People with intellectual and developmental disabilities are 4 times more likely to be victims of crime. A study conducted using data from the National Survey of Children's Health found that children with special health care needs were bullied 1.5 to 2 times more than non-impaired children. People with IDD are also subjected to traumatizing incidents of physical restraints and seclusion, something their typical peers rarely encounter. People with IDD have significantly higher rates of emotional neglect and serious injury compared to their non-disabled peers. And they may have chronic medical problems that necessitate surgeries and other invasive procedures. And psychological distress secondary to medical procedures is another category of potentially traumatizing experiences that is more common among people with developmental disabilities than their typically developing peers. A year-long investigation and analysis of unpublished Department of Justice records found that people with intellectual disabilities experienced sexual abuse at a rate of more than 7 times that of people without a disability. In this series, which aired in January of 2018, journalist Joseph Shapiro interviews sexual assault survivors and talks about the challenges people with IDD have in obtaining legal justice. In June of 2018, NPR reported that many states have started proposing legislation to do something about this epidemic. There is still much work to be done. When people with intellectual disabilities reach adolescence, their sexual development may not be well understood, given persistent myths that this population is asexual or alternatively hypersexual. Increased vulnerability to sexual abuse in this group may also stem from increased risk of early puberty, multiple caregivers providing intimate care, and education and communication barriers. The Bureau of Justice Statistics National Crime Victim Survey has consistently found that people with disabilities experience violent victimization at a rate of 2.5 times higher than people without disabilities. The groups with the highest rate of victimization, those with cognitive and independent living disabilities. Why is this rate lower than some of the other studies? A few reasons. For one, researchers have found that people with IDD may be more likely to underreport victimization compared to non-disabled peers for fear of coercion or shame. For another, these national surveys are often what are called household surveys, and they do not include people living in institutions or group homes where people with IDD are most vulnerable to abuse. Even when crimes against people with IDD are reported, the likelihood of people receiving protection under the law has also been found to be extremely low. In one study, they found that only 6% of cases went to court and only 1% resulting in conviction. So we know that adults with IDD are at risk for trauma. We also know that they are more likely to suffer from ongoing negative effects of that trauma because of barriers to receiving effective treatment. Some of the reasons for this are due to the high rates of out-of-home placements. This could result in difficulty gathering a detailed trauma history. There are few peer-to-peer networks, which could provide additional sources of support for the traumatized person, and they may have experienced multiple disrupted placements throughout their childhood and adulthood, which may be very traumatic in itself. Providers often feel insufficiently equipped to support people with IDD and trauma histories. Too often, these adults are seen as difficult to work with and are misunderstood, leaving clinicians uncertain about how to move forward in treatment. Clinicians may fear, lack interest, or may have resistance to acquiring cultural competency with this population due to disability stigma and lack of awareness of the problem. There is also a lack of trauma-informed service providers. They fear what they don't know, and they focus on the question, "What's wrong with you?" versus "What happened to you?" Treatments for adults with IDD often focus on behavioral compliance. Traditional evidence-based trauma interventions often exclude this population. The default is to utilize a behavioral focus due to communication limitations. Adults with IDD exhibiting challenging behaviors often do not receive state-of-the-art mental health treatment. Instead, the focus is often on managing their behavior with compliance as the primary goal. Cultures of care in both residential and community or family settings have historically been similar, with a goal of reducing maladaptive behaviors by focusing solely on consequences and replacing undesirable behavior with behaviors deemed appropriate. It may be much more helpful to address setting conditions, such as the unstable home environment or traumatic history, or antecedents to the behavior, like trauma reminders of the person or earlier frightening experiences. While positive behavior management can be effective in changing challenging behaviors, if underlying trauma and other mental health issues are not addressed, the likelihood of positive outcomes is greatly reduced. Traumatic stress can lead to potentially chronic changes in learning, behavior, and physiology, which may place adults with IDD at even further risk of becoming a victim to further trauma. People with IDD are underidentified and underserved, and lack trauma-informed services when required. There are many barriers to accessing the care they need. Diagnostic overshadowing is a term used when behavior or distress are misattributed to an individual's disabilities, preventing professionals and other caregivers from looking beyond the disability and assessing for possible mental or physical illness. For example, caregivers and family members who are accustomed to seeing the individual through the lens of the disability can misinterpret behaviors that are in fact symptomatic of mental illness, distress, or past trauma. In attributing challenging behavior solely to the disability, opportunities for recovery are missed. This in turn results in significant problems with trauma treatment access, frequent misdiagnoses, and poor treatment quality. This is particularly tragic given the staggering, well-documented rates of abuse and neglect in the IDD population as we discussed. We also know that people with IDD are less likely to spontaneously recover from traumatic stress, so the need for properly adapted trauma treatment is evident. There are inadequate trauma screening and assessment tools. While many trauma screening and assessment tools exist for the general population, they may need to be adapted in order to be effectively utilized with adults with IDD. This will be addressed more in Module 5. There are also assumptions made about the inability of people with IDD to engage in treatment. Professionals often make incorrect assumptions about adults with IDD and their capacity to engage in commonly used therapeutic techniques and strategies, such as cognitive behavioral therapy. It is important to provide better information to treatment providers about how to assess for a person's abilities, strengths, and needs. Even highly educated providers and family members are often not exposed to cross-training for co-occurring conditions. Higher education and continuing education programs have not provided enough opportunities for building capacity to serve adults with IDD who have experienced trauma and/or other mental health conditions. High-quality integrated care is necessary, and the intensive case management needed for successful trauma treatment is resource-intensive for this population. Among the professionals that do serve the IDD population, there are high turnover rates due to the provider's secondary traumatic stress and burnout. Also, high levels of supervision and intensive case management are usually required. Authorization denials require advocacy and complicated appeals. This takes considerable amounts of time, all of which is non-billable. Diagnosis, treatment planning, and crisis prevention requires a comprehensive interdisciplinary evaluation and significant expertise that may not be available in all communities. Many communities are accessing this expertise through training, online consultation, and learning communities. Fragmented services. Availability and quality of services varies across region, state, and communities, depending on funding and the structure of services. And these services often occur in silos, with little coordination between them. Adults may have a different care coordinator and different treatment plan at each of several systems without any of the providers talking with each other. And people may be excluded from services like mental health or trauma treatment explicitly because of an intellectual disability. Low reimbursement rates for services results in very limited access to highly trained providers. As a result of low reimbursement rates for services, providers who run group homes, day habilitation programs, and the like often employ college students and those with limited education, training, or skills in providing services and care for people with IDD. So then, is it any wonder when we hear a client say, "We went to them and they had no idea how to help us"? Unfortunately, the needed expertise to help them is not easily found in many communities, and even less so when trauma is involved. It's important to be aware of your biases and perceptions when it comes to people with IDD. Here are a few common myths about people with IDD. People with IDD cannot engage in treatment. Standard mental health treatment is ineffective for people with IDD, and behavior modification is the only option. We know that this is not accurate, given that there is an increasing amount of research and anecdotal case examples supporting the effectiveness of adapted trauma treatment for this population, including cognitive behavioral approaches. People with intellectual disabilities do not experience trauma. We know that this is not true. In fact, we understand that the opposite is true, given what we know about the relationship between personal resources and traumatic stress resiliency. Working with this population requires significant specialized training. The truth is that while it is important to obtain training on IDD and trauma, it does not require significant specialized training for qualified trauma therapists to provide treatment to people with IDD. A challenging behavior is explained by an intellectual disability. Challenging behaviors may result from many things, including pain from a medical illness, a psychiatric disorder such as depression or anxiety, distress that is hard to communicate, and trauma. Youth with IDD are protected from trauma because of their mental age. They don't remember. Recognize that IQ scores don't tell you anything about the adaptive functioning of the person, about any traumatic experiences and responses, or the emotional state of that person. This obviously isn't the entire list. Is there anything that you would think of? These statements are not true, but are commonly believed and contribute to adults with IDD who have experienced trauma not receiving the care and treatment they need. Through the course of this training, we will disprove these myths. What are the frameworks you use in your work? Do you work primarily in an IDD setting, such as a day program or residential setting? Do you work in a mental health setting, such as a community mental health clinic, private practice, or a psychiatric hospital? Do you work in a trauma-focused setting, such as an emergency room, crisis support, or adult protective services? Some people work at the intersections, for example, a community mental health clinic that specializes in trauma recovery, or a crisis support program for people with IDD. Let's talk a little bit about the various kinds of frameworks that people who interact with people with intellectual and developmental disabilities use in their work. Mental health and trauma treatment providers may have a variety of frameworks or theoretical orientations that guide their work, such as CBT, family systems theory, psychodynamic theory. However, generally the focus is on recovery and resilience, the perspective that people can recover or enhance their functioning. Providers in the IDD world tend to use frameworks that focus on creating adaptive environments to increase opportunities and build skills. Recovery isn't necessarily a familiar term in the IDD world. We want to change that and incorporate it into our daily language. This toolkit seeks to do both, focus on creating adaptive environments to increase opportunities, such as supportive health and safety, and recovery, build people back up, help them overcome traumatic experiences, feel good about themselves again, and thrive in daily experiences. A brief note about the definitions we use in this course. This toolkit is focusing on intellectual and developmental disabilities broadly. We recognize that within IDD, there is a wide range of functioning, and individuals vary in terms of the challenges they experience, depending on the nature of their disability. While generalizations are not possible, the purpose of the toolkit is to identify some specific issues and examples that allow providers to think about the types of questions that may be important for further exploration when working with people with IDD. We will further define IDD in Module 2. There are many more frameworks for understanding the traumatic stress response of adults with IDD. These frameworks arise out of multiple disciplines that interact with people with IDD, but there are often diverse frameworks within a discipline. This toolkit won't describe in great detail all the possible frameworks but many of them can be described in the biopsychosocial framework. This framework demonstrates that a person's current state is the product of biological influences, such as physical disabilities, genetic difference, neurological difference, psychological influences, such as previous traumas or stressors, coping abilities, cognitive abilities, and social influences, such as formal and informal support networks, culture, and public policy. We'll talk about a few more useful frameworks as we progress through this course. All behavior is communication. This is an important framework from positive behavioral supports. A trauma-informed approach also recognizes that a person's behavior may reflect underlying trauma. We need to consider the possibility of trauma and strive to truly listen to what the person is trying to communicate in order to help them heal. Below you'll find references for videos that reinforce the way in which people with intellectual disabilities, including people with multiple and severe disabilities, communicate. We encourage you to review these videos before proceeding.